Good afternoon, everyone, and thank you for joining us today. My name is Katie Bray, and I am Involvement and Engagement Manager here at Alzheimer's Research UK. It's my pleasure to welcome you to today's event, in which we will discuss whether blood tests are the future for dementia diagnosis. I'll be joined by Dr. Ashvini Keshavan and Dr. Maura Malpetti, who will share their research into blood tests and other methods used to diagnose dementia and answer your questions. Before we get into the discussion, I'll just go over some housekeeping. During the event, you're welcome to switch on the subtitles using the CC button at the bottom of your screen. These subtitles are generated automatically and so not 100% accurate during the live event, but they will be edited so that they are correct on the event recording. After today's event, we will send you a link to the event recording, which you'll be able to watch on our website or on our YouTube channel. This is also where you'll be able to find all the previous recordings like this. If you would like to ask a question during today's discussion, you'll need to click the Q&A button at the bottom of your screen, which will bring up a box where you can type your question. We know today's topic is of great interest, and so we'll do our best to answer as many questions as possible, but apologies if we can't answer your question. Just to note, we will not be able to answer specific medical or clinical questions directly related to your health, as this isn't the best forum to do that in. But first up, we are going to ask you some poll questions so we can find out a little bit more about you. These should pop up on your screen now. So these questions ask for your reasons for attending today, how you rate your current knowledge of dementia research, and if you've attended one of our online events about research before. So do start answering those, and I'll just pause for a moment to let you pop your answers on there. Oh, yes, I can see the results starting to come through. We've got a mix of reasons why people are coming today. Many people are here because they have a friend or family member affected by dementia. Quite a lot of people because their work relates to dementia. Some carers, some people who don't have a personal connection but just want to find out more. And it looks like most people rate their knowledge around the average mark. So we'll see by the end whether we've managed to improve that at all. And also we've got a nice mix of people for whom they've come to many of these events before, but quite a few people for who this is their first event. So welcome to you all. I hope you find it all very useful today. For those of you who are newer to these events, I'll just briefly introduce Alzheimer's Research UK. We are the UK's leading dementia research charity, and we're working to revolutionise the way that we treat, diagnose and prevent dementia by investing in the best research, powering the most forward-thinking scientists and joining forces with world-class organisations. But all this is only possible thanks to our amazing supporters who donate, fundraise, volunteer and raise awareness of our work, plus so much more. And with your support, we will keep going until every person is free from the heartbreak of dementia. And my team put on events like today so that you can hear directly from Alzheimer's Research UK funded scientists as they share and discuss their research and how it can change lives. So without further ado, it's my pleasure to introduce our guest today. So first up, I'd like to introduce Dr. Ashvini Keshavan.
Thanks very much, Katie. My name is Ashvini Keshavan. I'm a consultant neurologist at the National Hospital for Neurology and Neurosurgery at Queen's Square and a senior clinical research fellow at University College London. And my work is focused predominantly on blood tests for Alzheimer's disease. I'm one of the joint leads of a very recently funded study, which is one of two studies that is being funded by a Blood Biomarker Challenge grant, which is a multi-million-pound award given by the Alzheimer's Society, Alzheimer's Research UK, the National Institute for Health and Care Research, and supported by Gates Ventures and the funding raised by players of the People's Postcode Lottery. And the aim of this work is to revolutionize dementia diagnosis with the aim of unlocking access to personalized care and support, allowing people and their families to plan for the future. We want to try to bring a test or tests to the NHS within the next 5 years, which would allow us to make that difference in people's lives. Now I'd like to turn over to my other co-panelist, Dr. Maura Malpetti.
Hi, thank you very much, Ashvini, and hi, nice to see you all virtually all. It's very exciting to be here. I'm Maura Malpetti. I'm a research fellow at the University of Cambridge. In particular, my fellowship is funded by Race Against Dementia and Alzheimer Research UK. So I'm very excited to discuss a bit more the work that we are doing with Alzheimer Research UK for these blood tests. My research in particular focused not just on Alzheimer's disease. Maybe some of you read in the news that or out there that Alzheimer's disease is just one of the many diseases that can lead to dementia. And here in Cambridge, I focus also on other types of dementia, like for example, frontotemporal dementia. And what we are trying to do is looking at different blood tests that can differentiate these different diseases, but also trying to link these with other techniques. And we can speak a bit more in the discussion, but one example is brain scans. We look at structural MRI or magnetic resonance imaging, or the positron emission tomography, or what you may have heard as PET. And with this, we can look at changes in the brain, and we link that with what happens peripherally, and also what we can see in the blood. One example of this application of these different techniques is looking at the immune system, and we look at the inflammation and how the immune system in the brain relates to the immune system in the rest of the body. And using these different techniques, we can look at both. So looking at markers in the blood and also what happens in the brain. And we saw that, for example, inflammation is one of the components that relate to clinical decline in people with dementia. And so now I'm leading a new study, freshly funded, to start this On Fire study, which is a multi-center study that will cover all the UK and more than 22 centers across the UK to try to develop a new blood test to look at the inflammation in frontotemporal dementia and related conditions. So I'm very excited, and I think we can start the discussion. I'm sure a lot of you will have a question, so maybe Katie, you can start with that.
Yes, yeah. So as I said, we've had so many questions in advance. I could already see lots popping through today. So to get us started, I think first we probably just want a little bit of a summary, Ashvini, on actually how diagnosis currently works in clinics like yours. So what tests are you currently using, and what are some of the limitations of those?
Thanks very much. I think the first thing to make us all aware of or remind us of is that clinics like mine are only sort of one model of how dementia is diagnosed in the UK. I'm a neurologist, and so the patients whom I see are predominantly people who have either younger onset or atypical forms of presentation of problems with memory, thinking, and behavior. So a large number of people in this country are not seen in clinics like mine, but in memory clinics, which are services led predominantly by consultant psychiatrists and community mental health teams. And they cater to people over the age of 65, perhaps who have more typical presentations, and the pathway to being diagnosed in such a clinic is through a referral from your GP. So there is a lot of variation in practice in terms of how people are diagnosed in the UK. And there are some guidance materials out there as to how and what information should be incorporated into giving a person a diagnosis. And that guidance covers what reviews and tests a person might have in the GP setting first, to then be referred onward to a specialist, such as a memory clinician or a neurologist. And then also what those specialists might do in their clinics to arrive at a diagnosis, or to attempt to arrive at a diagnosis. And the main bits of information that are really important and perhaps universal are the history, which is the patient's account of their symptoms, but also their significant others' account of the symptoms or what they have noticed. And that might be a person living with them, a friend, somebody who knows them well from work, anybody whom they nominate. And then examination, which might involve some basic tests of a person's memory function at the GP level to screen that they think that it's concerning enough to be referred onward. Or it might, in the specialist setting, involve some more detailed examinations of memory and thinking, known as neuropsychological testing. And also bits of examination that could be relevant include physical examination, neurological examination, or mental status examination that a psychiatrist might carry out in more detail if they think that major contributory factors could include a person's mood, anxiety, depression, etc. Those might also be detailed in a more clear way. And then there's also tests. So we can have scans. The guidance suggests that most people in whom dementia is being considered as a possibility for their presentation should have either a CT scan or an MRI scan. And these are generally widely available across the country, but as to which scan you get could be variable. And some basic blood tests to rule out some reversible causes of memory and thinking changes. But they are not the blood tests that we're going to be talking about in detail today. They are things like ruling out anemia, making sure that certain vitamins are not low, that you don't have certain infections that might be treatable causes of the problem. And then in more specialist settings, such as mine, we are very fortunate to be a center where we do have access to this test. There is cerebrospinal fluid testing or lumbar punctures. But I'm aware of the fact that perhaps only about somewhere between 2 and 4% of individuals who are referred by their GP with a concern about their memory, thinking, or behavior end up actually accessing that test. So there's a lot of variation in access and inadequacy of access to that test at the moment. And then there are, in a very small percentage of people, some other types of scans. So what we call PET scans. A PET scan is essentially a scan that gives you an injection of a particular tracer. A tracer is just a substance that goes to a particular part, in this case of the brain, and tells you something about the function of it. So it might be how much glucose the brain is using up, or it might be whether there's a presence of a particular protein, such as amyloid. I hope that's not too detailed summary, but it gives us a state of the lie of the land.
Yeah, thank you. That's really good to hear. So Maura, coming to you. So not thinking of blood tests yet, but I know your research, as you said, looks at more than just blood tests. So what other tests are you looking at in the kind of research stage of things that could come through to change how diagnosis happens?
Yeah, like Ashvini mentioned, like there are different, of course, cognitive tests, but we are really focusing on the biology behind what happens in people with dementia and what are the potential causes leading to symptoms. So to do that, like we have this powerful tool, like Ashvini mentioned, also PET. The PET is a type of scanner that you inject the dye and you can target different little bits that we call proteins or other targets. This has been quite powerful in the research because basically part of those proteins or junk bits in the brain are those that we are trying to develop treatments for. So basically there are like some treatments out there that are trying to clean these junk proteins. And it seems that more there is an accumulation of these junk proteins like amyloid or tau, and more like this leads to death of the brain cells and eventually also the symptoms. So we are using that. That is one of the techniques that we use. And also we use the MRI or structural magnetic resonance, and that gives a different information. Is more about looking in the brain where actually cells die. And this is very important also for the diagnosis, not just for research, because of course, like symptoms can manifest very similarly across different diseases, and looking at what happens in the brain and where happens in the brain help us to give a more specific diagnosis and also eventually predict what we can expect that comes next in terms of symptoms, in terms of decline. So yeah, they are very powerful tools, but like maybe like in the discussion we'll come across also why we need to pair this with blood tests.
Thank you. Yes, actually, thinking of like the current status and what's coming through in research, like what is it that you're really looking for that would make diagnosing dementia easier or quicker to do?
So I think that there's a key distinction between a person's symptoms and what the underlying causes of that might be. Because as Maura just referred to, different regions of the brain that do different things might be affected by different processes. And so, for example, a person with Alzheimer's disease that happens to affect the back of their brain, the bits that do the processing of visual and spatial information, might actually not present with a memory problem, but more with a problem in processing vision and space. So being able to do up their buttons properly or find an item in the cupboard where there's a lot of different bottles to choose from. So these sorts of questions of how a person's symptoms relate to the actual underlying causes are really important, because identifying the underlying cause of a person's problems is the first step to being able to treat it effectively. But also in the current situation where we may not have specific treatments readily available for certain neurodegenerative conditions, it's still important to be able to give people a perspective on the outlook for the future, what they can expect for the kinds of adjustments or support they might need in their lives and how they might want to plan for the future, and for those around them in terms of how they can support them. So I think that what we would ideally want to be able to do is to be able to get more from assessing a person that tells us about the underlying cause than purely to describe the symptoms, which is what we're perhaps better at doing now, is describing what we see in terms of how it manifests. And to get at the heart of what is causing the problem, you need something that tells you about the proteins that Maura referred to, the junk proteins that are the basis of many of these diseases. And how would you access those proteins? The lumbar punctures that I spoke about before are currently one of the main ways to do that. And then the specialist scans that look at certain types of protein one at a time with individual tracers, these injected compounds. That's another way. But ideally, we want to be able to do this in a way that's not as invasive as a lumbar puncture and not as expensive as a PET scan. And that could even be repeated over time if there was any doubt that we didn't pick it up the first time, for example, or if technology advanced and we were able to add more tests to the suite of things that we could look for. And the way to do that would be to get something from them that's easily accessible, so a blood test. And we would ideally want to be able to say, you know, your blood shows evidence of X, Y, and Z underlying causes of, or potential causes of your symptoms. But we'll discuss a bit more as to how close we are to making those sorts of statements, I think.
Yeah,
But that would be the ideal.
Yeah, really good summary there of what would really get to the heart of the problem. So Maura, thinking of some of the blood tests that you're working on, a lot of the questions that we've had ahead of time is, well, what's actually being measured here? You know, is it people's genetics or is it something else that's being measured? Because, you know, there's different things that we can pick up in blood. I wondered if you could expand on that a bit more.
Yeah, there are different tests for different reasons. So like there are genetic testing that can capture some gene variations that can actually cause the disease or predispose someone to lead like a higher risk to develop specific types of dementia. The blood test that both Ashvini and I are looking actually is to measure more the changes in the brain and in the body and in the brain. So basically those junk proteins that we can measure with PET imaging, for example, in the brain, we're trying to capture that with a simple blood test. And as also Ashvini mentioned, like with the PET scan, the downside of that is that you can just measure one protein at a time because you just inject one dye that goes to a specific target. Well, what we are looking in the blood is a panel of different potential markers and different tests that we can do from one single blood sample, so we can measure different things. In particular, we are looking at the accumulation of different proteins that are those junk proteins like tau, signs of amyloid, but also like in particular in my study, we are looking at changes in the immune system. So we are looking at how the immune system cells are activated. We count the cells that are in the blood, and also how they communicate with chemical signals. So these are just examples. There are like also way of measuring, for example, neurodegenerations or markers that tells how much the brain is suffering and how many, how much actually is losing in terms of cells, and many others, metabolism, etc., etc. Or also how the brain cells stop communicating quite well, or like they lose synapses. So there is a lot in terms of research trying to understand different mechanisms with one single blood test, and that is very powerful. What we are trying to basically, when we say what happens in the next few years, what we are trying to bring in clinics, I think the most important aspect that everyone in the world is really trying to focus on is identify those proteins that are the junk proteins. And this is very important to differentiate people that have symptoms related to neurodegenerative disease, or also to differentiate the different diseases. So it is Alzheimer's disease or something else. And I think that is something that we are trying to really answer in the short term.
Brilliant, thank you. So Ashvini, coming to you with the study that you're just starting now, you're looking at a blood test and it's for Alzheimer's, isn't it? Could you tell us a little bit more about what that blood test is trying to measure?
Sure. So the study that we're referring to is a recently funded study called ADAPT, which is Alzheimer's disease diagnosis and plasma phospho-tau 217. Quite a mouthful. But the blood test that we're measuring is something called plasma phospho-tau 217. And the reason why we are going for that one, and actually in this case putting all our eggs in that one basket, is that plasma phospho-tau 217 has been shown in other studies of quite well-selected, carefully researched individuals around the world to show a good difference, a quite wide fold change between people who have Alzheimer's disease, defined very carefully with things like lumbar punctures and amyloid PET scans, versus either completely healthy people who have no symptoms and also have a negative profile for Alzheimer's disease, or people who have other conditions, other dementias, but have a negative profile on the gold standard test for Alzheimer's disease that I mentioned before. So what remains is to show that that blood test could actually be given to or requested in people who present in an unselected way in the real world, in your average memory clinic or neurology clinic in the UK, and that it would actually make a difference to the person having the test to have that diagnosis supported by the blood test information. And what the aim of our study is, and how we've figured out the number of people that we need to do the study in, is that we want to show that the blood test, the information from it, would increase the rate of Alzheimer's disease diagnosis by 10% in the people who have the information of the test to hand, the people and their clinicians, as compared to people and their clinicians who don't have the information of that blood test to hand. So it's actually a trial of a blood test, which is an interesting design, and not one that is commonly done in the blood test field. We would anticipate that the primary result would actually be able to be known quite quickly, because we'd actually look at the primary result within 3 months of a person being recruited to that trial. And the entry criteria for our trial, because I know that a lot of people perhaps on the call are asking the question of, can I get the blood test? We have chosen to implement this trial in the context of UK memory clinics. So you would have to be somebody who is being assessed in a memory clinic for the first time. So would have been referred by your GP to the memory clinic with a concern that your presenting symptoms could be related to a dementia-causing illness. And the doctors who assessed you, the doctors or other clinicians who assessed you in that memory clinic, would need to agree that they think that Alzheimer's disease is a possible cause of your symptoms, because we don't anticipate at this stage being able to offer it. We don't want to put the cart before the horse and try to examine it in all people, regardless of their symptoms and their presentation, we think the most important and pressing need is to ensure that this blood test is useful to people who have symptoms suggestive of dementia first. And if we can prove the use case there, it would then make sense to start going further back in the symptom timeline. And also the adoption of such blood tests in the NHS, first and foremost, has to be related to how useful they are versus how much they cost in the ultimate setting. And you'd want to show it in the case where you anticipate that the impact's going to be highest first.
So do you imagine, so say the blood test does work, it does detect what you think it's going to highlight, would you still be then looking to do others? Is it the first thing someone would do when they came in, you do the kind of cognitive test to understand what's happening symptom-wise, but you would do the blood test before going to other tests? And would it then mean you didn't need to do as many invasive tests, or would it filter people out?
So at this stage, we're thinking that we would do the blood test still in a secondary care setting, a memory clinic or specialist setting, rather than in GP. But it would be early on in that process. So at the first time a person would attend. And that would be the same time as when they might have a bedside assessment of their memory and thinking, a sort of brief memory test, as well as the same time as a scan was being requested. Though the blood test result might come back in advance of a scan being reported, we would anticipate that the clinicians would integrate the information from all of these sources to make a diagnosis. And I must stress that we would never anticipate that the blood test would be used on its own to make a diagnosis when other aspects of information were all pointing in the other direction, for example, away from that and perhaps to a mood disorder as the cause of the problem. So I think that it is a tool, but not a standalone one.
Yeah, maybe I can add one thing on this. Like, I completely agree with Ashvini that like it should not be a standalone test. And also I think it will be we will need to consider what we do the test for. Like if it is like a binary selection, is like there is a diagnosis confirmed or not, the blood test as other techniques can be very helpful. For other things like, for example, predicting or forecasting how the trajectory or the next types of symptoms that we can expect in these people, maybe we need that spatial information in the brain scans that we cannot have from the blood. So I completely agree with you that we probably need a combination of different tests and also for different reasons.
Very good. Yes, exactly. Ashvini, I'm just going to come back to you. We've had a question come in live, just a little, which might be quite useful to kind of open up. So you're measuring this pTau 217 in the brain. Could you just tell us a little bit about why that, how is it arising? How is it linked with the disease of Alzheimer's disease?
Excellent question. So Alzheimer's disease is actually defined by certain protein changes in the brain and certain patterns of cell loss in the brain. And Maura has referred to the two key proteins which form part of the definition, which are amyloid, a protein that is deposited outside of cells and builds up in things called amyloid plaques. And then tau, a protein which is deposited and has a change called phosphorylation, which is just basically the tagging of that protein inside the cells with a particular tag. So people with Alzheimer's disease have increased tau deposited inside the cells that then eventually go on to have problems with communicating with each other and then dying. And the phosphorylation, that tag on tau, is something that we've known exists through looking at people who kindly donate their brains after they pass away to research. We've been able to look at their brains under the microscope and find that particular tag inside those cells. So a lot of work over the last few years in trying to get both spinal fluid tests and blood tests was to see if we could find a similarly tagged protein in spinal fluid and blood. And that's eventually now come to pass with the advancements in technology that allow us to pick up very, very small amounts of proteins in blood. So that's why we've gone for it, essentially.
It's the best one. It's like that like a signature for the disease that you can pick up in the blood.
Yeah, and 217 as opposed to other tags on other places on the same protein seems to be a bit more convincing in terms of providing that separation in levels between people with Alzheimer's and people who don't have it.
Wonderful, thank you, really good explanation. So Maura, coming to you, you've talked about, you're not just looking at Alzheimer's, you're looking at kind of other diseases as well. So do you need to first identify something for each of the different diseases you're looking at to then hopefully create this sort of panel of blood tests that you're kind of aiming towards as the grand ambition? And yeah, could you just tell us a little bit more about some of those, disease signatures that you're trying to pick up?
Yeah, that's a very good question. Something that we could start with is that very often we hear speaking about this amyloid, and it is like the main target of some of the treatments that have been talked about in the last few years. That is a protein, for example, that is not present at all in people with frontotemporal dementia, or like in a small portion of people with this condition. So it's something that we need to keep in mind when we speak about these blood tests. When we think oh, there is a new blood test for dementia, we always very often refer to Alzheimer's disease related to that then leads to dementia. The problem is definitely the blood tests that we have at the moment, they are very good to exclude the Alzheimer's disease as a cause of dementia, and then based on other assessment, like with cognitive assessment, with MRI and other measures, we go beyond that and trying to understand is frontotemporal dementia, is dementia with Lewy body, or other types of dementia. At the moment, there are not very, let's say, super useful markers for these other types of dementia, but there is so much work on that. Like there are other proteins that we hear much less in the news, like TDP43 is another junk protein that is related to specific cases of frontotemporal dementia, and there are a lot of new blood tests that are trying to develop these specific markers for these other types of pathology. Ideally, I think in the future, there will be a panel where we have a good marker for all of them, not just Alzheimer's disease, because at the moment we can exclude Alzheimer's disease from these cases, but we cannot say anything about actually which is the pathology that is going on. So in the future, if we can test multiple markers, we may be able to have a much more precise diagnosis that relate to the specific syndrome and cognitive symptoms. Yeah.
Wonderful. So it's a process. It's not going to suddenly happen overnight that, there's these amazing panels, but we're taking the steps towards that.
Yeah, I think we start from one and then we combine all of them. Yeah.
So Ashvini, the study you're working on is one of these early ones that's hoping to kind of identify and validate, prove that this is a good approach to take. So given the timelines that you're working to and how quickly you can get people in to test this out, what timeline could you imagine for, if it works and it does what we're hoping, that actually it might be rolled out to anyone accessing kind of a diagnosis in the NHS?
So widespread rollout, as I mentioned, is not just about validating a test and knowing that it works, but knowing that it's appropriate for all the settings in which it might work, and that real life factors like, if you took the blood test in a location that's 200 kilometers away from the lab where it's being processed, will the results still be valid if that blood sample was jostled about in the back of a truck, dropped on the floor, these sorts of things. And part of the initial work in our study is actually going to examine what are these, what we call pre-analytical factors. So effectively, how much you can mistreat a sample and the results still be the same. And these kinds of things are really important to be able to know that it is going to be easily able to be rolled out, and in what way. Because if we find that you have to treat it rather preciously, then you can immediately see that it's not going to be as easy to roll out. But another aspect has to do with the actual performance. So with tests, what we want to know is it sensitive, meaning is it able to pick up the presence of the disease that you're looking at, even when the values, the increases are very small? And is it specific, which is it going to be the rise in that blood test going to be seen just in people with, say, Alzheimer's disease, as opposed to other things that could be impacting it, like, people who have impaired kidney function might have reduced clearance of the protein from the blood, and that might cause it to be slightly elevated. So we need to say and find out by how much could that influence things. And another aspect, which I think is really important and which the UK has a strength in being able to investigate, that perhaps some of the other around the world cohorts would not have had, is the ethnic and socioeconomic diversity angle, which we are looking to definitely investigate as part of this, to establish that the blood test is similar and in what it says in different people of different backgrounds is really important. So with all of that in mind, I think that the initial things that allow us to say that it's fit for purpose, fit for use, will mean that it will be requestable in some form, but perhaps in specialist clinics in the first instance within the year, but that the evidence for it being supportable on the NHS for more widespread rollout, and that would really go through an approvals process over in the NHS as a whole, would require the kind of evidence of it making a difference to people's outcomes and lives. And that is a sort of longer aim of the trial, which the trial will eventually complete in 5 years, including the sort of how cost effective it is. And could it be recommended by NICE, for example, to be integrated into the standard of care, would take the full 5 years of the study. But yeah, it's a staged process, and I'm really optimistic about progress that we're making so far.
Wonderful, thank you. I know it's really hard when I'm asking these questions to put that sort of timescale on, because there are so many moving parts. Just looking at some of the questions that have come through, and there's one that I think is maybe quite interesting given the recent change in government. So if you had that opportunity to get in front of Wes Streeting, our new health minister, and if he would say, what's one thing that we could do to accelerate your research? I'll come to both of you on this, but Maura, do you want to take this one first? What could the government put in place to accelerate your research?
I think two key things can really accelerate the research, and one is for sure funding. Like, of course, all these research studies are very expensive, and rightly so. We need to do the right thing. So we need to validate this in large scale, not just in one center. We need to involve all the country. So of course, funding is always like the tricky part, but also awareness. I think like what the policymakers can really help researchers and families is to raise awareness about these conditions, about the research that is ongoing, about the new treatments, about the new tests, and about the difficulties, and also acknowledge the difficulties of the families in this condition and how urgent is the problem. It's something that we cannot wait other 5 or 10 years to solve. We need to be quick to solve and reduce the situation. Yeah.
Your shot with Wes Streeting, what's your ask?
I would agree with those two. I'd say that in terms of funding, perhaps it's not just about funding specific studies, but about funding the infrastructure that supports research in a more widespread sense. And there is an infrastructure that, works very well and perhaps works rather very efficiently. And the people who work in, for example, the NIHR's clinical research networks are extremely highly motivated and very efficient people, but they are being stretched to deliver more and more in terms of studies. And we want to really be able to make it easy for people who are attending clinics that are not necessarily part of academic institutions that are well linked with CRNs to be able to participate in research. And part of that has to do with empowering them to be confident in what research does and to be happy to participate in it. So that's the awareness side. But part of that also has to be with literally making it accessible by making it easy for CRN people to access them or expanding the reach of the CRNs, the clinical research networks.
Brilliant, thank you. I guess maybe a slightly broader question. So we've really focused today on diagnosis. But a question we often get asked a lot by people is, well, at the moment, the treatments are on offer once you've got a diagnosis. There aren't that many, they're not that effective. So why is researching diagnosis so important when that's the current state of treatment? And, could you talk a little bit about, why researching diagnosis is so important? I don't know who wants to take that one first.
Shall I
Yeah, go
give
for it.
a go, like for the research side maybe, and also, yeah, for the diagnosis. It's true, like the treatments are coming up more and more, and we are, I think, in the peak. Like we have been working for many years in this field, and I think is the most exciting, era for this field. I think it's very important because there are not just things that can be done in terms of the ultimate cure, but there is also a lot of that can be done in terms of management of the symptoms, of the prognosis, and also like to be supported as a family, not just as a person with dementia. And I think in terms of research, definitely we need everyone involved because we are so different one another, and we need that diversity to understand, like, for example, better how to use these blood tests, which treatments are effective in which part of the population. So if we are all united and part of that, early we get the diagnosis and is more likely to have like treatments that will help everyone and not just a subpopulation or some like a group of people that are part of the research. So I think that is very important.
Ashvini, do you have anything to add to that?
Yeah, so I think the other key aspect that, and I'm going to relate this a little bit back to blood tests, because the blood tests being able to help diagnose people more accurately and earlier could also be really important for another aspect of research, which is ongoing, which is clinical trials. And already there's, for example, some clinical trials that are using, not in the UK, but in other places, phospho-tau 217 and plasma as a recruitment strategy to screen in or out people who are likely to have Alzheimer's disease pathology. So that's just an example of how research in one field then impacts the eventual development of a treatment, because if the moment any one of these trials reads out as having a positive a benefit to people with the condition being studied, then it starts on the road to being able to be approved as a treatment that could be accessed by patients, perhaps not those who are very severely affected, but those who are mild or moderately affected now and then in the future. So that has been the route to the current 2 drugs that have been approved in the US for treatment of Alzheimer's disease that are supposed to be amyloid lowering therapies, that they went through a clinical trial process first in order to be able to be approved. And being able to select the people who go into the trial as definitely having the condition is at the crux of the matter. You need to know who you're trialing it in to know then who you can generalize the results to in the future.
Thank you. So given we are getting close to our time, I just want to return back to our kind of initial question and get just a short summary from each of you. So to you, are blood tests the future? And what really needs to be in place to make sure that they are the future? Maura, do you want to go first? Oh, Ashvini, go on. Yeah.
I was just going to say that I think that they are part of the future. I don't think that they will provide answers on their own. And I think a key point is that you still need information of where in the brain, the spatial information of where in the brain is affected. And so scans have to impact on that. And how a person is affected is very much to do with their individual circumstances, the social framework around them and everything else that only comes from talking to the patient and examining them properly. So I think that they will change the future. They'll certainly be part of it, but they're not the whole story. But I'm really optimistic that in our lifetimes, and this is really exciting to be a small part of this, we can stand to make a difference using blood tests.
Yeah, I completely agree. I completely agree. And I perhaps added that I think it's part of the future. They will be definitely part of the future for more democratization of the research and the clinical trials and treatments, because like maybe we didn't even touch this, but some of the PET scans or other very fancy tests are not accessible everywhere. For a combination of costs, a combination of technologies that don't reach all countries, don't reach all parts of the UK, for example. Light. But yeah, so I think that will be part of the future in terms of also involve everyone in clinical trials, in research and better diagnosis.
Brilliant, thank you. Well, I think given that our time is coming up, I'm going to just say a huge thank you both to Ashvini and Maura for sharing your research, discussing this promising area of research, and for answering as many questions as we could. So thank you to you both, and we'll say goodbye to you now, but everyone else, please do hold on. All right. So before you go, we just have some final information to give you. So first up, we just want to do a quick poll for some feedback. And this really helps us to get a sense of how today has gone. So that should hopefully pop up on your screen now. So it helps us to understand whether the content of what we talked about, was it too technical? Was it about right or too simple? Would you recommend these events to friends and family? And do you feel like you've learned something new today? So I'll just give you a couple of seconds to start to fill that in. Because yeah, this is really useful information. We do this poll now, but in the coming days, we'll also be sending out another survey with a thank you email, in which you can give us more detailed comments and information about this event. And this is so valuable. It helps us to understand what's working well, but also where we could be making improvements. So all and any feedback you can give us is greatly appreciated. Just see if we've got any more coming through. I think that's that's most people. So yes, wonderful. Thank you so much. It looks like most people felt the content was about right, and that they agreed or strongly agreed they would recommend, and that they feel they've learned something today. So that's really good. I'm really pleased to hear that yeah, we've been able to meet that today. As we've had lots and lots of questions today, both in advance and on the day today, and I know that there may be some that you put to us that we haven't been able to answer, or some where you might need more personalised information on kind of your situation or where to turn. So just want to share our Dementia Research info line, and that they're here to help. The team can answer your questions and signpost on to other organisations who can offer support. You may also be interested in finding out more about Join Dementia Research, a service that can match you to research studies. We've heard quite a bit today about some research studies that are ongoing, and this is the place really that you can register to be in the know about what's going on and what you could take part in. So the service is open to anyone over the age of 18, and you do not need to have a dementia diagnosis to take part in studies. You can have one, but you don't have to have one. You can find out more on their website or by calling the Dementia Research info line. And I think we'll be posting those details in the chat, and we'll also be sharing them in our follow-up emails. Our next event like this is planned for 1 p.m. on Tuesday, the 24th of September. And we'll be joined by Professor Jason Warren and Dr. Fiona McLean, who will be sharing their research into understanding how risk factors for dementia actually work to increase our risk. And they'll be taking your questions. You can sign up to this event online from today, so on the same page where you signed up to this one. And again, we'll be sharing that link. I want to say a huge thank you for coming along today and taking the time to find out more about dementia research. As you've heard, we are making huge advances to improve how we can diagnose dementia and how this is vital for finding better treatments and ultimately a cure for dementia. Thank you for all your support that has got us to this point. And if you're interested in other ways to support the work of Alzheimer's Research UK, do check out the website, as there's lots of other ways to get involved. So finally, a huge thank you from me and from the team for joining us today. I hope you've enjoyed it and found it useful, and we hope that you can join us again for another event in future. Goodbye.